Welcome to Chapter 18, Impact of Cognitive and Sensory Impairment on the Child and Family. We're going to be looking at developmental disability, also known as intellectual disability, autism spectrum disorder, Down syndrome, and then sensory impairments, specifically visual and hearing. Intellectual disability overview. Intellectual disability involves significant limitations in intellectual functioning and adaptive behavior with the onset before 18. Prevalence is approximately 1%. This does fall into the DSM-5 diagnostic criteria. So we have intellectual functioning with an IQ less than or equal to 70 to 75. The DSM-5 emphasizes full clinical assessment. We have adaptive functioning with deficits in communication, social skills, self-care, academics, and safety, must affect independence and social responsibility, and then developmental onset. Symptoms must begin in childhood. Etiology, causes could be due to genetic disorders like Down syndrome, Fragile X, or PKU. Prenatal or perinatal complications like substance use, infections, prematurity, and hypoxia. We can also have environmental deprivations, traumas, infections, and toxins. However, approximately 30 to 40% have unknown causes. So the severity levels. Mild is the most common. They have mid-elementary academic level. They're independent with minimal support. Moderates have first to third grade academic level. They need supportive living and help with complex tasks. Severe is limited language, requires extensive support with help and self-care. And then profound is going to be nonverbal, total care, multiple physical impairments. They usually have a shortened life expectancy. Associated conditions can be autisms, seizures, cerebral palsy, sensory impairments, mental health conditions, and communication disorders. Nursing assessment. Remember, every child is an individual. They need individual care, and that care should be prioritized. And it should be developed based on the child's cognitive and adaptive functioning. We need to understand what is their developmental age and what is their ability to understand, and then we tailor it to that. We want to assess their developmental history, their adaptive functioning, their communication skills, their neurologic status, their family coping, their environmental setting. Your nursing management is going to focus on safety, nutrition, self-care training, consistent routines, communication support, social skill development, and individualized development goals. We want to use visual supports, simple language, repetition, and positive reinforcements. For behavioral support, we want to identify the purpose of the behaviors, teach replacement skills, maintain predictable routines, and collaborate with behavioral specialists for maladaptive behaviors. For family support, we want to educate on diagnosis, skill development, home routines, and behavioral strategies. We want to provide emotional support, acknowledge grief reactions, build on strengths, and connect families with community resources and early intervention skills. Autism spectrum disorder. Um, this is a neurodevelopmental disorder appearing before age 3. It affects communication, social interaction, and behavior. It is a wide spectrum from very mild to severe. The etiology, we know that there's a strong genetic component, possible prenatal factors like maternal infections and toxins. It is not caused by vaccines. Your DSM-5 criteria, they're going to have some type of social communication deficit. So this might be eye contact, could be relationships, They're going to have restrictive, repetitive behaviors. So maybe it's routine, maybe it's sensory issues, maybe it's a fixated interest. Symptoms begin in early childhood and they do cause functional impairment. So we have some common comorbidities with this, like ADHD, anxiety, depression, seizures, GI problems, and sleep disturbances. Your clinical signs are going to be delayed or absence in speech. They might have echolalia, where they're repeating what you say. They can have literal language, where they cannot abstractly speak or think. Limited eye contact, lack of pretend play, the repetitive behaviors like hand flapping, rocking, distress with routine changes. And it's really important as a nurse that you remember distress with routine changes, because if we want to make sure that we're providing structured routines for them. And then also sensory issues. They might have hypo or hyperactivity. Red flags that need to be evaluated. If the child's not babbling or gesturing by 12 months, if they do not have a single word by 16 months, no two-word phrases by 24 months, any regression at any age, any lack of eye contact, or the child doesn't respond to their age. Screening starts around 18 to 24 months, but again, if we're having these red flags, we might look at it earlier. Prognosis, this is a lifelong condition. Outcomes improve with early intervention and intensive interventions. It's a better prognosis with functional speech and higher cognitive abilities. Your nursing priorities: provide structural routines, which is hard in the hospital, but we need to maintain the family standard routine the best that we can. So, bedtime is when bedtime is, TV time is when TV time is, school time is when school time is, and we try to work our hospital requirements around it the best that we can. We want to reduce sensory overload. So when you're thinking about, you're doing your vital signs and that machine's binging, that can be very distressful. So you want to make sure that your settings are appropriate on your monitor. You want to use visual supports, simple communication, enhanced safety. We want to support the family and collaborate with multidisciplinary teams. Down syndrome. Down syndrome is the most common chromosomal abnormality and a leading genetic cause of intellectual disability. It's characterized by distinct physical features, developmental delays, and a varying degree of cognitive impairment. Chromosomal causes. So we can have trisomy 21, which is about 95%. And if you remember from genetics, we have a strand of mom's DNA and dad's DNA that come together, and as they are dividing and replicating, what ends up happening is one of the two. It was usually always thought to be the mom's. When she divides off at 21, she keeps both of hers, and then we get one of dad's 21. So now we have three 21s, which is why it's trisomy 21. So you have three 21 chromosomes. With translocations, part of the 21 breaks off and it attaches to another chromosome. So it's sometimes 15, 21, or 22. A risk factor. So maternal age greater than 35, they say has stickier DNA, so they're at higher risk for trisomy 21. Previous child with Down syndrome, if the parent carries that translocation on their genetic coding, then it will show in the child's genetic. A family history of Down syndrome, again, for that translocation. Clinical manifestations. Facial features. So they have a flat facial profile. They have upward slant to eyes. They have small skin folds at the inner corners of their eyes. A small nose with a depressed nasal bridge. They have a protruding tongue, which appears large compared to their small mouth. They have low set ears. They might have white spots on their iris. They could have shortened head with a flattened back of their skull, short neck with excess skin nap, small head circumference, which would be that microcephaly, body and extremities. So these kids usually have hypotonia, which is decreased muscle tone. That's considered a very significant finding. Hyperreflexia of the joints, which is kind of like lax ligaments. Short stature, short, broad hands and feet. Single palmar crease, which is known as the simian crease. Wide space between their first and second toes. Um, Other physical features, we can have dry, rough skin, which is prone to cracking, sparse, fine hair. And then there's also medical conditions, cardiac defects occur in about 40 to 50% of these kids. So they can have some endocardial cushion defects, which would be the AV canal. They can also have ASD, VSD, PDA, and tetralogy of Fallot. We can have gastrointestinal abnormalities like duodenal atresia or stenosis, Hirschsprung's disease, transesophageal fistulas, and celiac disease. They can also have an imperforated anus. Respiratory issues. These kids are at an increased susceptibility to upper respiratory infections, chronic nasal congestion due to that underdeveloped nasal bone, sleep apnea, and increased risk for pneumonia. We can also have some sensory impairments like hearing loss and vision problems. Endocrine disorders, 10 to 20% end up with hyperthyroidism. We can also have an increased risk for diabetes. They have some hematologic issues like increased risk for leukemia, polycythemia in infants. Neurologic intellectual disability is usually variable severity from mild to moderate, but they're going to have some form of intellectual disability. And then there's also early onset of Alzheimer's, which we see around age 40, and seizures occur in about 5 to 10% of them. Other issues, they can have dental problems from delayed eruption, missing teeth, or malocclusion. They have increased risk for obesity in childhood and adult, male infertility, and immune deficiencies. So when we're looking at the the developmental and cognitive features, um, intellectual disability present in all individuals, but severity varies widely. Most will have mild to moderate intellectual disability. IQ ranges from about 25 to 70. Learning occurs, but it's going to be at a slower pace. Developmental delays, motor milestones are delayed. So, delays in sitting, walking, and feeding. Speech and language delays are common. Social development, often a relative strength. With our behavioral characteristics, they're generally happy, they're generally affectionate, they can be a little stubborn, they have some attention difficulties, and we're noting an increased risk in autism spectrum disorder with Down syndrome. So, our management for these guys. Um, Initial disclosure when we're talking to the families, timing and setting is important. Most infants are diagnosed at birth due to the very distinct features. Parents should be informed as soon as the diagnosis is made. It's good so that parents are together so they have a good support system, or whoever the birth parent is with their support system. Communication principles. We want to be clear. We want to be honest. We want to be compassionate. We want to emphasize that every child is unique. We want to offer immediate support. We want to avoid giving too much information initially. Parents may be in shock and not able to absorb it. Some resources, we can do educational resources. We want to make sure that we're using reputable websites and organizations. We want to share current evidence-based information. And we want to use materials that show Down syndrome with positive images. Referrals, parents should go to support groups, professional counseling, early interventions, pediatric specialists like cardiology and genetics, and then whatever community resources are out there. when we're talking about nursing management of the physical child, we can look at managing the hypotonia and positioning. So there's a lot of challenges from that decreased muscle tone. These kids are almost like a rag doll effect. Parents sometimes perceive that lack of molding to the body as like a rejection. So we just need a lot of reassurance and education that sometimes they're difficult to hold or they might be a little bit cumbersome. They have this hyperextendability of their joints. So we can do some good strategies where we swaddle or wrap the infant snugly before we pick them up to provide security and warmth. We want to extend body position to promote heat loss. We want to change position frequently to promote respiratory expansion. We want to support joints during handling. We want to educate the parents that a lack of clinging or molding is a physical characteristic. It is not a sign of detachment or rejection. Allow the parent time to discuss feelings and concerns and demonstrate proper handling. When we're looking at respiratory management, again, problems from that hypotonia and that anatomy, they'll have decreased muscle tone, compromise for respiratory expansion, underdeveloped nasal bones, constantly a stuffy nose, lots of mouth breathing, which is going to dry those oral pharyngeal membranes, which is going to put them at an increased risk for upper respiratory infections. So we want to do interventions like clearing the nose with a bulb syringe, rinsing the mouth with water after feedings, increase fluid intake. We might want to make sure we have cool mist so that keeps those membranes moist and secretions liquefied. Change position frequently, good hand hygiene, properly dispose of soiled tissues. And then if we do end up with an infection that requires antibiotics, making sure they're doing the complete course of antibiotics. Feeding management, feeding challenges, inadequate nasal drainage, mucus pooling kind of interferes with feeding. The mouth breathing makes it difficult for them to suck for extended periods. They have that protruding tongue, which interferes with feedings, especially solids. Many gag on food due to that dryness of the oral pharynx. Tongue thrust is what they do. It's not refusal. So again, lots of education on, this is them. They're unique. Things that we can do. Feeding strategies. We want to clear the nose before feeding. We want to give small, frequent feeds. We want to allow for periods of rest during meal times. We want to position upright during and after feeding. For solids, we want to use small but long, straight handled spoon. Push food toward the back and side. If food thrusts out, refeed. Don't interpret this as refusal. We want to burp frequently and monitor for aspiration. Nutrition monitoring, dietary intake needs supervision. Decreased muscle tone affects gastric motility, so they're predisposed to constipation. So we may need to add on increased fiber and fluid. We want to scrutinize eating habits to prevent obesity. We want to obtain those height and weights and use a Down syndrome specific growth chart. For skin, um, infancy, the skin's really pliable and soft, but it slowly becomes rough and dry, and then it becomes prone to cracking, which can lead to infection. So we want to use minimal soap. We want to apply lubricants regularly. We want to use lip balm to prevent chapping. We want to protect from extreme temperatures, and we need to monitor for breakdown so that we prevent infection. Cardiac care, we want to monitor for signs of congenital heart. So, are we having cyanosis, tachypnea, poor feeding, failure to thrive? Do we hear a heart murmur? All infants with Down syndrome should have a cardiac evaluation. There's usually an echocardiogram in newborn period with cardiac follow-ups. They may need surgery, and we always want to monitor that growth and development closely. Hearing. So there's a few types of hearing loss. We can have conductive loss, which is typically can be fixed. It results as a transmission issue. We can have sensorineural damage to the structure or nerves, commonly congenital, but can be due to infections, drugs, or excessive noise. Then we can have mixed hearing loss. And with mixed hearing loss, we can have central auditory, all hearing loss. We can have conductive with fixed underlying, and then we'll be able to hear with like a hearing aid or amplified sound. And then if we have the sensorial hearing loss, we can use colloquial ear implants. So, types of hearing impairments, um, understanding the different types, whether it's conductive, sensorial, or mixed, is crucial for the appropriate care and interventions. The impacts on development, hearing can affect speech, language development, social skills, and academic performance. So, early identification and intervention is really essential to minimize these effects. Every baby should have a newborn screening. Care should be individualized. And remember things that we might see, those clinical manifestations, depending on the age in a little newborn, would be that lack of startle reflex, lack of that marrow, because they can't hear you to startle. As the child gets older, they might be talking or yelling very loudly, because they do not hear themselves well. And then once they get into school, we're going to see delays in school and learning difficulties because the lack of being able to hear. Visual impairment is a general term that encompasses both partial sight and legal blindness, genetics, prenatal, postnatal complications. Your nursing management for this is to identify those who, by virtue of their history, are at risk, observe for behaviors that indicate vision loss. Remember, kids that are starting to have vision loss might have delays in their school. They might be complaining about headaches. So those would be, kiddos that you'd want to assess for vision, and screening all children for visual acuity and signs of other ocular disorders such as strabismus are things that should be occurring. And that is the end of this lecture. Thank you.